Hello, good evening. Thank you for joining us. I'm Dr. Szabo with up in the Blue Ash Pod of the Urology group. We're going to be talking about bladder control issues and specifically stuff with overactivity of the bladder. We've done a couple of these before, so this is kind of be, if you've joined it or watched some of the other ones, going to be kind of more along the same line of those ones. But if this is new to you, hopefully we give you some good information here, something that you can use and make an appointment to see me or one of my partners. So you can submit questions off to the side, and I'll do my best to get through everything towards the at the end of the program here. Like I said, I am up in the Blue Ash Pod, but I also do see people once a week down in Norwood at our surgery center there. So if you want to make an appointment with me after this, just give our office a call, 841-7800, and I'm happy to see any of you. So what we're going to do is kind of talk about, understanding what, how the bladder works, what treatment options there are, what do we need to do, and kind of go into a little bit more detail about some of these. Now, this talk is sponsored by Medtronic, who makes one of the devices or two of the devices that we're going to talk about. I have no financial stake in them or any disclosures for any of you guys. So almost half of people say that they're embarrassed to talk about bladder problems when they have them. So that could be whether or not you're going to get control of your bladder, going out on a date, going to a celebration, to a graduation, going and getting a job if you're leaking all the time or having to run to the bathroom, not being able to leave the house. And, it can cause a big impact on people's quality of lives. So the main bladder control problems that we're going to talk about are stress urinary incontinence, or that I'll mention are stress urinary incontinence, urinary retention, and overactive bladder. And we're going to focus on mostly on number 3. So stress incontinence is more the leaking from like laughing, coughing, sneezing. If you're getting up from sitting to standing or exercising, you leak a little bit or a lot of it. And that is something that we can fix. And me and my partners do have ability to help with that. So if that's something that's bothering you, please make an appointment. That this presentation is not for you if this is your main issue. Urinary retention is kind of an issue where your bladder is more underactive or just can't empty for a variety of reasons. If you can either can't tell your bladder's full and can't empty your bladder all the way, you have weak stream, you need a catheter. For most patients, these therapies that we're going to talk about today are not going to work or not be applicable. Now, there are certain cases where they are, but you would need to see one of us to discuss that further. So the main thing is overactive bladder. So overactive bladder is often thought of with like an urgency frequency. So you're going to the bathroom all the time. You get off the bathroom and 15 minutes later, you're back on the toilet, going at more than 8 times a day, never really emptying all the way. Sometimes with what we call urgent incontinence, you have the urge to pee and you just can't hold it. You can't make it in time and you leak before you can even get there. And if that's you, that you're not alone. That's, overactive bladder affects 1 in 6 Americans. That's more than the number of people who have diabetes in this country. So it's a lot. And so this can really affect your quality of life for a variety of reasons. So that's, just breaking down those numbers, that's about 43 million people in the United States who have overactive bladder, and that's more than the number of people who have significant vision problems and diabetes combined. So there's a lot of you out there. So what's normal is not leaking. So urinary incontinence is not a normal part of getting old. Now, sometimes things slowing down a little bit can be a part of getting old, but this frequency, urgency, needing to go right away, having to plan your day around where bathrooms are, those are all, this is nothing that you have to live with, and there's things that we can do to help with that. So there are treatments that we can give and things that we can do to help get things better. So it's important before we kind of go into this to start by talking about kind of the way that bladder function works in a broad sense. And the reality is that your bladder fills up with urine, that the kidneys make. And as it gets full, the nerves from the bladder send signals to your brain, and your brain basically tells your bladder, it's not full enough, not full enough. And then eventually, okay, I'm going to start consciously letting us know that it's time to go find a bathroom. And then when it's time to go to the bathroom, you send signals down to your bladder to give it the green light to empty. So for whatever reason, during the course of people developing an overactive bladder, you basically lose communication between the brain and the bladder. There's a variety of reasons why that can happen, but basically there's a communication breakdown. So one of the things that we're going to talk about, which is the InterStim device, it's essentially a nerve stimulation to the bladder to try to restore normal function and try to restore normal communication and quiet these noisy signals that are going on. So there's a number of things that can cause control problems of your bladder. So a lot of times it might be daily habits. If you're one of those people who drinks 1.5 pots of coffee a day, well, caffeine is going to really cause some problems. Sometimes certain medications can cause irritability of the bladder. There's a lot of other things that can cause it too, that can relate or that can cause long-term issues there. So typically what we need to do is we need to first diagnose the problem, then we see if there's certain lifestyle changes that you can make. So again, if you're consuming a ton of caffeine, or if you get triggered by spicy foods and you're eating a lot of spicy foods, well, we say maybe back off on some of that stuff. But typically, if you're at the point where you're seeing us in the office, we're going to start you on some form of medication. And the one thing I want to say, if you're thinking about coming in, just know that a lot of times it takes some trial and error to find what's going to work. Most people don't stick with the first thing that we give them. And a lot of times that's because of side effects or just the medication not being effective enough. And that's kind of par for the course, is for us to have to try a few things. And then eventually there's certain advanced therapies, or what we call third line therapies for overactive bladder, that can be very, very effective when medications have failed. But because insurance dictates the way we provide healthcare in this country, you are typically always going to have to try and fail for a variety of for whatever reason, at least 2 medications before advancing to these third line therapies. So like I said, so lifestyle changes, diet and exercise. Being overweight certainly contributes to things, because as you're moving around, there's just more weight of your body that's getting pushed on the bladder, so it makes it a little bit more sensitive. There's things that you can do with, like, either exercises or what we call biofeedback, where we kind of train you to have a better sensory control of your bladder, and that can be effective for kind of milder cases. But then what we talked about was oral medications. So they can control symptoms, but sometimes they can cause other issues. It's a daily medication that you take. Some of these medications that are typically started by primary care doctors, or people who don't do this more regularly, can be not great for older adults, or some of these medications have been linked to early dementia. So we got to be really careful with what we're prescribing based on who you are and your other health conditions, how old you are. A lot of these meds cause dry mouth, dry eyes, blurred vision, constipation. Sometimes there's one of them that can cause elevations in your blood pressure. And so in general, there's one survey where 72% of people said they stopped taking their medication within 6 months. There's other large studies that look at how often people are renewing their prescriptions, where up to 90% of people are not continuing with their very first therapy. So we got to we work together on this, and so there are some people who respond to the very first thing we give them, but oftentimes we're trying different things. So these advanced therapies, or these third line therapies, are either sacral neuromodulation or nerve stimulation, and that's the InterStim. There's peripheral tibial nerve stimulation, or this Medtronic neurosystem. I'll get into all these things. And there's BOTOX injections as well. So for BOTOX, I apologize for the formatting on here. It looks like there's some overlap of stuff. So First of all, in a vacuum, its effectiveness is comparable to sacral neuromodulation or the interstim system. However, there's certain things you need to know about the Botox. First, so it's a minimally invasive thing. It's, take a look with the scope into your bladder, and we inject your depending on what dose of the drug we're giving. And that does need to be retreated every 6 months or so on average. So sometimes people can last 3 months. Some people last 9 months. I have one person in my practice where the Botox lasts for just about 1 calendar year. But generally speaking, it's about 6 months. So the way that the Botox works is that it's kind of a more powerful form of the medications, which are designed to kind of suppress and these nerve signals and kind of partially paralyze the bladder. So because you're kind of partially paralyzing things, it does create about a 10% risk of having urinary retention where you can't really pee or can't empty all the way after the procedure. So 90% of the time it doesn't happen, but there are a certain number of people who would need to be able to cath themselves or use a urinary catheter for a short period of time until the Botox wears off enough for you to be able to pee. Now, the other thing that can happen is that there's about, no matter what we do, there's about a 20% chance of getting a UTI. So if you're, if let's say you're 60 years old and we say that the average life expectancy would get you to be around, let's just say for our purposes, 85. So that's 25 years. If it lasts 6 months, that's 50 cases, which means that you will almost certainly get a UTI at some point in that time, probably multiple if you're treated with Botox for a very long period of time. And what we've seen is that a lot of people do end up stopping Botox treatments after a few injections just because of either infectious issues that pop up or just the need to have one thing after the other. And so the last thing about it is it doesn't really address that whole bladder and brain communication that we talked about earlier. So one other option for, and we use this sparingly, this is usually for people who are maybe less willing to undergo a surgical procedure or maybe a little bit older, have other medical conditions going on, where essentially what we do is we put this little electrode, I don't know if you can see it in this picture, we put this little electrode down onto a nerve that sits behind your ankle. And that nerve goes in to your spinal cord and plugs in at the same place as the nerves that go to your bladder. So stimulating this nerve by just where it plugs in also kind of stimulates the bladder nerves too. And so this can help with reducing these overactive symptoms of frequency, urgency, urgent continence. And the biggest downside with this is that it is a big time commitment. So it's you go once a week for 12 weeks, and it's about 30 minutes each time where we give you the stimulation. And if it works and you're happy with it, then you get a maintenance therapy every forward. So the time commitment of this is kind of scares some people away. So the next thing, and we're going to spend a little bit more time focused on this, is the interstim or sacral neuromodulation. So essentially what we're doing is we're putting in a little, what looks like and then works like a little pacemaker for the bladder. So we implant this kind of in the upper outer portion of your butt, and there's a little wire that goes down and sits on the nerves that go to your bladder, which is down in your sacrum, which is the bony plate at the bottom of your spine that where the nerves emerge from. So providing like a real gentle stimulation kind of for, we don't know why it works exactly, but we know that it does. And we generally provide this stimulation and it restores normal function. We have people who can go from peeing 30 times a day down to 8 times a day. Our goal with any of these things is a 50% improvement, but about a quarter of people who do this get a 100% improvement of their symptoms. So there are recharge free and a rechargeable device. If you see, the kind of bigger one is the recharge free device and the smaller one is the rechargeable. Now, we had been doing a lot of rechargeable ones before because the battery life on that was about 12 to 15 years. and the old battery lasted about 3 to 5 years. Now this new model, the InterStim X, will last somewhere between 8 to 10 years on average. So most people are just getting that battery put in, and by the time you would need your battery to be changed, most likely there would be another model that would come out that would last even longer. So the good thing with the non-rechargeable is that you don't really have to do anything. It's just in there and it's working. And so before we can put this in, we do need to do a little test to see if it works. So there's kind of two ways of us doing this. There's a basic evaluation and a more advanced evaluation. And most people opt for the basic test, which at our group we do at our surgery center down in Norwood. Essentially what we do is we give you some numbing medication, and we put these little wires down onto the nerves that go to your bladder. And these nerves kind of come out right up at the top of your butt crack, and we have them taped to your back. It's attached to a little temporary battery that's in this little fanny pack that you see on this picture here. And you can just wear it around your clothes, and we see how you do for the first for like 1 to 2 weeks, depending on your presentation. And we see if you get a 50% improvement. If you're happy with the therapy, then great. We move on with the implant. So out of the people who use it, 84% are satisfied with the therapy. There's a 3 times greater improvement in quality of life compared to any of the medications that people would have been taking beforehand. And about 82% of people have success of this at 5 years. So it's a sustained response where you have one surgery, one test, and then a surgery up front, and then you don't really need anything else other than just maybe occasional reprogramming of the device. This has been around since 1999, so it's not really a new technology, but there have been advancements in making sure that it doesn't move or get out of position, and the amount of pain that people have afterwards has gone down significantly from about 30% to about 3%. So it's a very, very good therapy, and people generally are very happy with them. There have been about 350,000 people who've had this done and who have an InterStim in them and are working very well. So if you are somebody who has these really significant overactive bladder symptoms, this does say urinary retention symptoms. There's a very select group of people where this could be effective for that, but this would require a big other workup for that. But if you've tried making lifestyle changes, tried medications, and they either don't work, or they cause side effects, or they're too expensive, then these are good options for you. So here's just a little patient testimonial saying that she's getting back to doing things that she loves to do, and it kind of has really made a big difference in this person's life. So I'm going to just look at some questions. I see there's one question off to the side here, which I'll answer right now. So question is, I started Gemtesa last year, overactive bladder. It worked pretty well, but I had to stop after 5 months when the cost jumped to $600 a month. Very, very unreasonable. Is there a different medication that is less costly and just as effective? So there are other medications that are less expensive. The ones that are less expensive, if your insurance doesn't cover a drug like Gemtesa, which I think is my favorite drug of all the ones on the market, if it's not covered and you're being asked to spend $600 a month, there's things that we can do to try medications that are very, very, very reasonable and what you would expect to pay. So, either if it's covered by your plan, not paying anything, or getting it for $15 to $30 a month. Now, if there's a different medication that's less costly, that the answer to that is absolutely. Is it just as effective? Hard to say, because everybody responds different to different drugs. Sometimes the other drugs are just not as effective in one person and maybe more effective in another one. So it would be something that we'd have to try. But eventually, if you're trying one thing after the next, it's you might want to just think about one of these more advanced options, either the BOTOX or the interstim or the peripheral nerve stimulation. So another question is the ankle thing approved for MS? The implant isn't. So there's a little bit of nuance in that question. So people with multiple sclerosis, about 90 to 95% of people will develop some form of urinary symptoms in the course of their life with that diagnosis. And it can be really a debilitating part of that. Now, people with commercial insurance and MS can get the implant with no problem. The issue that we've been running into for people with MS who are on Medicare, which frankly is most of the people who are coming into our office, it's the problem is that Medicare is starting to decide that they're not going to approve things or retroactively come back after physicians practicing physicians in the doctor's offices for putting these things in. Now, there's no medical reason for that because there's a lot of people with MS who can be really, really helped with this. But that's something that where we could always try for unless there's some other contraindication, we could try doing the ankle stimulation if you've been denied for the implant. But sometimes after, if we try everything else and exhaust our resources, sometimes we can get an exception. So I'd encourage you to come back in and see me or whoever you've been seeing to help with that. Another question is, can we save the webinar and replay it again? Yes, this will be, this is being recorded and this will be posted on our website afterwards. So there is another one that says, I've been taking trospium for 12 years to control bladder spasms, but now I'm experiencing spasms up to 6 times a day, where it used to be once a week. None of the other medications have been effective. Well, I think for you, you're a perfect person to come on in and talk about either BOTOX or the nerve stimulation. Sometimes if there's something else that we uncover during the course of you coming into the office, sometimes we need to look with the scope and just make sure there's nothing physically in your bladder, or excuse me, in your bladder that would be causing that. But assuming everything looks normal down there physically, it might be a wiring issue, and we, again, some of these advanced treatments can be very, very effective. So here's another one. Oh, there's a very good question. So I have a pacemaker for a low heart rate. Are the Medtronic systems still possible? So the interstim device is possible, and you can have a pacemaker and have the interstim, but you cannot do the ankle stimulation. So the ankle stimulation is contraindicated for pacemakers, for cardiac pacemakers, but everything else you're good to go. So next one, does physical therapy work for overactive bladder and urgency? I think if you find a good pelvic floor physical therapist, you should be able to see some degree of improvement. Now, usually they're going to be kind of slightly different exercises than what you would do for stress incontinence, which is what we call Kegel exercises, where the squeezing exercises, where you're kind of strengthening the muscles. Sometimes you can do some of that. A lot of times it's learning different exercises to kind of distract your brain from an urge that's coming on. But certainly if you do physical therapy, it's not going to hurt anything by any means. And I always encourage people to see a pelvic floor physical therapist, once or twice, just in case there's something that you pick up that ends up being very helpful for you. So another one is I can't do BOTOX because of a swallowing issue. So that's one of the reasons, one thing where where BOTOX might not be a good option, just because there's an extremely, extremely low risk of BOTOX getting in the systemically and going throughout your body and not just in the bladder. I'm talking like less than 0.01% 0.01%, or it's something ridiculously low. There's been maybe just a couple reported cases total, but it is something that generally speaking, it's something that we just don't do in that situation. So you might be a good candidate for the nerve stimulation. Another question: how do you determine if the source of the problem is the bladder or the prostate? So that's a very good question. So this is for men. A lot of times it has to do with your symptoms. It's whether it's frequency, urgency, urgent continence, that stuff we've been talking about, or if it's just like a really weak stream, dribbling, straining to urinate, all that stuff. So sometimes they can be kind of hard to tease out, and a lot of that requires you to come into the office for us to see how well you're emptying your bladder. If you're emptying your bladder very well, that's kind of more evidence that it could be a bladder issue. Sometimes a prostate issue can over time lead to a bladder issue where the bladder kind of decompensates over many, many, many years. So, so that's, what I guess the take home point would be, there's stuff that we can do. There's tests that we can do to determine whether or not this is a primary bladder issue or a prostate issue, but that would require coming in to see us, and we'd have to do some certain evaluations in the office and potentially in the operating room. So another one, I take oxybutynin for overactive bladder, still waking up 4 times a night, having to go to the bathroom. What can I do? So for anybody whose main symptom is the nighttime waking up, and if things are really, really worse at night, I would encourage people to, especially if you know that you're a snorer, or if your partner says that you snore, you should definitely see a sleep medicine doctor and be evaluated for obstructive sleep apnea. The reason why is that sometimes people don't even know that they have OSA, but essentially what that is, it's your muscles of your throat become relaxed and close off your airway, and you trap air in your lungs, and that trapped air creates a big rise in pressure, and your heart interprets that pressure as you having excess fluid in your body. So your heart releases a hormone that acts like a diuretic or a water pill and causes you to make more urine, and make more urine quickly. And not to mention the fact that you're lying down typically at night, so you're getting more blood flow through the heart and through the kidneys, so more urine is being made that way. So people who have nighttime waking up, if there's any chance that you're snoring, or if you haven't been evaluated for a sleep disorder, that could, fixing that can potentially cure the nighttime waking up. But again, that's something where I would also encourage you to come see us in the office, because sometimes there's other things that we can see that might be contributing to that. It might be a bladder problem, not so much a sleep problem. So again, I would encourage you to come and see us and talk to us about that. Sometimes it could be even just switching to another medication. So some people say, another person, I'm triggered to urinate as soon as the bladder fills to a certain amount. Is this odd? No, that's very common. So certain people just basically have a capacity where once they go beyond that, it triggers spasms and triggers the bladder to empty. So there's things that we can do for that. These more advanced, the medications can help with that. And if you're already taking medications, these advanced therapies can help with that. They can work to really relax the bladder to allow you to hold more urine, so that you're not having to go right when you get to X number of ounces. So what are your thoughts on wearing disposable underwear? I mean, if you need to do it and you really don't want to undergo any of these other treatments, or you don't want to you either don't want to have the medications, or can't tolerate them, or they don't work, or whatever it is, people will wear them, and there's no real harm to that. But obviously most adults would prefer not to. So I would encourage you to come see us and see if there's anything we can do to get you out of those. And another question, I'm currently seeing a urologist at the urology group for kidney stones. Could I see you for bladder issues, or see my current urologist? I'm happy to see you for anything. We are all partners. There's things that I'm really good at that my partners aren't. There's things that I'm not good at all that my partners are. So if I am happy to see any of you, even if you're seeing somebody else in our practice. You can always check with your doc if there's a, because again, I'm in Blue Ash and in Norwood, so if those aren't really convenient offices for you, we have doctors kind of throughout the metropolitan area who do specialize in overactive bladder, and so there might be a doc at one of the offices closer to you. So I would encourage you to just give us a call, or maybe give your doctor a call and say, hey, I want to see one of the overactive bladder specialists. Is there somebody in your division, or would I need to go see Dr. Szabo, or again, there's Dr. Rodesheimer sees people, Dr. Bennett, Dr. Love. There's a lot of us who deal with this a lot. Is Medtronic, are the Medtronic systems covered by Medicare? Generally speaking, yes. So again, we've been running into some issues recently where Medicare, or CMS, which is the governing body for Medicare, updated their guidelines, and now they're trying to, let's just say, not pay for devices for people who otherwise should get the devices, and where they would probably work pretty well. So for the most part, if you meet some of the certain criteria, the Medtronic devices should be covered completely by Medicare, and we would let you know if there is some sort of exception to that. Have any anti-anxiety or stress medications been used for overactive bladder? Not really. Sometimes those medications can be used for people with what we call interstitial cystitis, or some like bladder, an inflammatory disorder of the bladder. But for overactive bladder itself, not so much. Another person is, I'm triggered to urinate whenever I arrive home or hear water run. Is that really a part of OAB? Is there a way to train my mind not to react to certain events like that? That is a little bit of a built-in, like, Pavlovian response, where your brain just associates you getting home with, hey, I'm going to need to go to the bathroom. So it starts the process off for you. There's not a we can try certain things to try to, I guess, retrain your wiring. A lot of times it's just a matter of not really worrying about the bladder, or excuse me, the brain so much, and focusing more on the bladder. And if we can control how well your bladder responds to these urges, then you're less likely to need to leak or have something like that. But yeah, it's very common for people, either getting home, hearing water run, getting in the shower, things like that. It's very, very common. And so we'll do just a couple more questions here. Someone with diabetes who catheterizes a couple times a day and still leaks. Any ideas? So, sometimes that could be that your bladder is just a little spastic. So we might need to do something to help with that. Now, typically, if your bladder is not really working to the point where you're self-cathing, the Medtronic, the InterStim, is not approved for that. So that in that case, you might be a good candidate for the BOTOX. And a lot of people in that situation, that's a very good option. What's a good normal frequency during the daytime to urinate? We say normal is anything less than 8 times a day. So it's hard to get people to urinate less than that with any of these therapies. So now for some people, normal is 2 or 3 times a day. For some people, normal is 8 times a day. But for any of these therapies, we're trying to get you to 8 voids or less per day. Another one, I take 2 medicines, but Medicare does not pay for either. Why is that? Well, that's a good question. I wish I had an answer for that. And I wish I knew why Medicare would not pay for medications that work and insist that you try medications that don't work, or medications that you can't have. But that's kind of the world we live in, unfortunately. So there may be other options for you, where you might have a medication that that you haven't tried yet that is covered. But ultimately, there are plenty of people who have advanced on to either these third-line therapies, either BOTOX or the interstims, where the main reason was that the medications that worked wouldn't be paid for. So the insurance companies would rather pay for a one-time surgery than pay for that medication month after month for years. So so I would say that if you're in that boat where your meds are just really aren't being paid for, and you're not getting samples anymore because you're kind of run your course on that, then then I would encourage you to come and see us, and you might be a good candidate for these third line therapies. All right, we're going to do one more question. So Gemtesa is fairly new. Is there a long-term downside to taking it? So Gemtesa and Myrbetriq are two drugs that are in a different class from all the old standbys. The old ones, which are called anticholinergics, such as oxybutynin, Vesicare, Toviaz, Trospium, all those ones. Those ones tend to cause more of the dry mouth, constipation, dry eyes, potential vision problems. You can't take them if you have glaucoma. If there's any concern for people, like really once people start getting in their 80s, especially if you're taking oxybutynin has been shown to be a contributory factor to developing earlier onset of dementia. So if you're over 80 and you're on oxybutynin, I would encourage you not to be. But as far as Myrbetriq and Gemtesa go, they're a different class of medications. Gemtesa's was approved in December of 2020, so it's the newest one that's on the market. Myrbetriq's been around a little bit longer. It's probably been around since, I want to say 2014, somewhere in there. And so there have not been any long-term consequences to taking those things that we're aware of. Obviously, there's sometimes there might be a medication that comes on the market where all the data shows that it's very, very safe, and then 20 years down the line, they realize that people taking this drug have some sort of effect. I don't think that would be the case. That's not very common that happens. So, the most common situation would be that if you're going to have a side effect from it, it would be an initial side effect where it affects you right away, and that would kind of stop you from taking the medication. But as far as we know, there's no long-term effects from taking it. So, well, thank you everybody for joining. I'm happy to see any of you. If my office is really inconvenient for you, again, I have partners all over the city. We have doctors who do specialize in overactive bladder who may be closer to you than where I am. But if you want to make a trek and sit down and talk, I'm happy to. So hope you guys have a great rest of your night, and hopefully we'll see you soon. And again, we will post this video on our website within the next couple days. All right, take care. Have a good night.